on to our program for today. So this is a really exciting program. It's been requested, and mental and emotional health is often a topic that's requested by participants. So we're very fortunate to have Dr. Chism with us today to talk about trauma, PTSD, and resilience throughout the transplant process. We get to Dr. Chism, I'm going to go through a few housekeeping slides. So we are recording this program so that if you want to watch it again, it'll be available to you. If you wanted to share it with other patients or caregivers who weren't able to attend, you could as well. So we'll include this in the follow-up email. Please feel free to chat in the chat box. You can share where you're calling from, what organ you're waiting for or have received, anything about your transplant story. If you have questions for Dr. Chism, please ask them through the Q&A. If you ask them through the chat, it might get lost in the chat, so it's best to put your question right into the QA. But also, please consult with your own transplant or medical providers if you do have a question that's specific to your care. Dr. Chism might be able to provide some resources for you to look into following the program, but if it's anything specific to you, it's important that you talk to your own team. Our next program next month is a patient panel. So that's where we bring multiple recipients together to share their story, how the process has been for them, and really how they're doing now. So the goal is that it really inspires and gives other patients hope that life can very well be normal, and it can be normal after transplant and really fulfilling. So please join this program. It's on June 22nd at 3 p.m. We'll have different recipients of different organs. Again, you can hold your camera up to this QR code to register, but it'll also be included in the follow-up email if you miss it. And then finally, before I hand it over to Dr. Chism, if you've been on our programs, then you've heard about CSL, who's been a wonderful sponsor of these programs. CSL is a global biotech leader driven by their promise to save lives. Their ability to innovate and deliver life-saving meds for patients with rare diseases and other unmet medical needs around the world has earned them a reputation for always putting patients first. CSL sees a significant unmet need in transplantation and are committed to delivering innovative solutions to address those needs. So again, thank you, CSL, for your support. And now I will turn it over to Dr. Chism, who is a transplant psychiatrist with Jefferson here in Philadelphia. She's been there since 2008, has also done a program for us, I think, right when COVID started in 2020. And we're very fortunate to have her with us today. So thank you, Dr. Chism.
Thank you so much. Thanks for everyone for being here. Now we do the part where I struggle to get my slides going. And now, am I sharing my screen? No, not yet. Let's zoom. There we go. Okay, hopefully that's right. Can you all see that? Yeah, you see the
Yes, sorry. Yep, we see it.
The good one. Okay. All right. Thank you so much. So so I'm going to talk today about transplant and trauma, PTSD, and resilience. And hopefully we'll have time at the end for some questions and discussions. So again, let's see, that's not working. There we go. I'm the chief transplant psychiatrist here at Jefferson. I'm also the director of the consultation liaison division, which means that I take care of folks who are sick in the medical hospital in the Department of Psychiatry at Jefferson. So basically, I'm going to start kind of first principles. You can't get a brain transplant. So we kind of are stuck with the brains that we have, which is a good thing for the most part. And what does our brain do for us? Our brain is responsible for helping us to survive. Everything that our brain does is really trying to help keep us safe and alive. And the way that it does that is by being very good at noticing patterns, at connecting with people socially, and predicting the future. And the reason that it's so good at that is because that again, that's how we stay safe, by knowing that when there's a rustling in the grass, that means that, there's potentially a lion there that could eat us, and having us react quickly to getting away so we don't have to stop and think about it is very good for us. But the problem is that traumatic events are registered throughout the brain, particularly in areas that impart emotional valence, that put an emotional history on things. And the reason is because emotion reinforces important information and helps to short circuit the ponderous process of thinking about things. So that way we act more quickly and more efficiently in the future. So if something bad happens and we recognize unconsciously and quickly that was a trigger that this is the situation that something bad happened in, when we can react. Just like, if you put your hand on a hot stove, you don't sort of stop like, oh, my hand is on the stove, I'm going to move it. Even just getting close to the heat makes you jerk away. But the harm of trauma in certain individuals is that it damages the circuits, where it's supposed to just store the memory, and it leads to reactions that are inappropriate, which is really, in a simple way of saying that the past doesn't stay in the past. And so what happens when things go wrong in our understanding of bad events is that we can have a lot of negative feelings. We can sometimes develop psychiatric illness, and the one that we're going to talk about today is post-traumatic stress disorder. And those things are different. So when things, having negative feelings, and when I go over some of the diagnostic criteria of PTSD, some people may have experience some of those things, but just having negative feelings and having some bad feelings and feeling anxiety, or sometimes having nightmares, or sometimes having flashbacks, or sometimes having panic attacks, each one of those individually does not mean that someone has PTSD. Those are unfortunate things that happen, and sometimes we have to learn to contend with them or treat them, but they're not the same thing as psychiatric illness. They're very different. So just to let you know that not all trauma results in people getting PTSD. For the most part, trauma results in people either adapting, or they might develop some depression or anxiety or substance use. But the PTSD is not the only thing that can happen from trauma gone wrong. And also, trauma can be a part of heroic living. Trauma can actually be a source of energy for giving and living freely. And it lets us transform from being a victim to being a survivor. And hopefully we'll have an opportunity to kind of talk about that and our experiences of that. So how common is PTSD? So approximately a quarter of individuals who experience major trauma develop PTSD. And more significantly, the lifetime prevalence of PTSD is about 10% in the United States. And that's a lot higher than in the rest of the developed world, actually. And in certain populations in the United States, it's even higher than that, maybe up to 40% in the urban poor. But it's about 20% in certain medical populations. And that's kind of obviously who we're talking about today, people with transplant. Now, there are many things that can happen to us after we have exposure to a traumatic event. We can experience a lot of negative physical symptoms. We can experience, chills, difficulty breathing, dizziness. Our blood pressure can go up. We might faint or feel tired. We can grind our teeth or get headaches. We might have nausea or pain. We might sweat or have a rapid heartbeat. We might have twitches or feel weak. We can have some changes in our mental functioning. We might blame others. We might be less alert. We might be more alert and hypervigilant. We might have intrusive images of the event, or memory problems, or nightmares. Sometimes we can't pay attention. Sometimes we don't make good decisions or have problem solving. We could have emotional dysregulation, agitation, anxiety, fear, apprehension, denial, depression, shock, guilt, grief, inappropriate emotional responses, laughing when things aren't funny, crying when things aren't sad, irritability, loss of emotional control. We may do things, our behavior is the things that we do that can happen after trauma. Some people drink more alcohol, may engage in some antisocial acts, just change what we're doing, change how we communicate, stop having sex, start having too much sex, changes in our speech, emotional outbursts, inability to rest, wandering around, pacing. We might have a change in appetite. We might eat too much, we might eat too little. We might be more easily startled. We might be somewhat suspicious of others. We might withdraw socially. All of those things, again, as I mentioned, are things that can happen after trauma, but they don't necessarily mean that someone has PTSD. These can be relatively normal and expected signs that something bad has happened. But if you want to think about PTSD, this is something I teach the medical students, that there is a mnemonic for the diagnostic criteria for actual post-traumatic stress disorder, which is trauma. So you've had a traumatic event, you might either re-experience it or have recurring thoughts about it. You avoid places, people, situations, and memories of it. You're not able to function the way that you could before. And you have symptoms for more than a month. And there are also mood alterations. And then you have increased arousal. That means that you're more jumpy, more paying attention. So this kind of goes over all of the what the diagnostic criteria mean. And the only reason I kind of put it here is just so that you can know that obviously to be diagnosed with post-traumatic stress disorder, there has to be an exposure to actual or threatened death, serious injury, or sexual violence in more than one or more of the following ways. Either it happened to you, you witnessed it happen to others, you learned that it happened to a close friend or family member. And the reason I say this is because obviously hopefully there are people here who both have had transplants and caregivers of transplant. Both of you or all of you, count as having gone through a traumatic event. You almost witnessed someone die, possibly the ICU, was prolonged. It happened to you, or you saw it happen to your loved one, or, you weren't maybe able to come into the hospital because of COVID when your loved one was being transplanted, but you heard all about the details of it. So all of us in the world of transplant are exposed to trauma. Now, in terms of making a diagnosis, you also, in addition to being exposed to trauma, you have to have at least one or more intrusion symptom. You have to persistently avoid stimuli associated with the trauma. You have negative alterations in cognition and mood, marked alterations in arousal and reactivity. And just so you know what intrusion means, is that either you have recurrent involuntary and distressing memories of the trauma, or recurrent distressing dreams. And so this isn't just thinking about it, but actually not knowing that when you're having the dream or when you're having the flashback, you actually believe that you're back in that moment. Also, dissociative reactions can happen in which you kind of like lose touch with reality and have intense and prolonged distress at the exposure to cues that are like the event. And that involves marked physiologic reaction, that you have elevated heart rate, elevated blood pressure, start to breathe, sweat, that kind of thing. And then avoiding the stimuli might just be avoiding thoughts. It can also just be avoiding emotions. And the negative alterations in cognition and mood are, either you can't remember something about it, or you have persistent and exaggerated negative beliefs about it, or you may blame yourself too much, believe that you're not worthy, that you don't do the things that you used to do, you feel detached or estranged from others, and in fact have a persistent ability to experience positive emotions. I mean, it can't be, I don't know why I'm not happy. I don't know why I don't feel good about this. I waited for so long for this, and now I just feel numb. And then the arousal can sometimes just be irritable behavior and outbursts, could also be reckless or destructive behavior, and sometimes it's hypervigilance. And in transplant, there's a lot of reminders, right? You can't really avoid the hospital. Even if you're doing well, you have to come back for your appointments. You have to take medicine. You have to get labs drawn. But so sometimes, going to, get even a minor procedure done, you can be, very worked up, anxious, and easily startled. Maybe have problems with concentration, and then sleep disturbance, of course, is all too common. And so for a diagnosis of PTSD, these symptoms have to go on for more than a month. Mm-hmm. And then acute stress disorder, which is something that can happen right after the event, is 3 days to 1 month after trauma. And unfortunately, it's a highly reliable predictor of developing PTSD in the future. So PTSD is not the only thing that people can suffer with after a trauma. There's a high comorbidity with people with agoraphobia, panic and depression, and substance use. And people with PTSD are 80% more likely than those without it to have symptoms that meet diagnostic criteria for at least one other mental health disorder like depression, bipolar, anxiety, or substance. And comorbid substance and conduct disorder is more common among males with PTSD than females. But more than the diagnosis, what are some risk factors? What are some things that we can look at going into transplant that might make us think about, well, we really need to be vigilant for PTSD and make sure that we do the right things to possibly help avoid it? Well, one thing is a history of trauma prior to the index trauma. So when I do transplant evaluations, I always ask people about their history of trauma. And I know that the social workers also do as well, because we know if you have a history of trauma, that can increase your risk of PTSD with another trauma. Also, a history of acute stress disorder. A past history of PTSD means that the risk of developing it again is very high. A past history of depression, a past history of an anxiety disorder, and also or having also a personality disorder. A family history of anxiety disorder. This is very important because, as I mentioned to you, that PTSD really comes from sort of the circuits in the brain that are trying to keep us safe being overactivated, and our ability to kind of remember to put the past in our brain as being abnormal. Folks with a family history and a personal history of anxiety disorder, we know that they have a slightly hyped up, early warning system that sometimes can make it easier for those circuits to go awry. Disrupted parental attachment. So people without, strong, loving, bonded childhoods often, have more of a chance of developing PTSD after something traumatic because they don't have the same kind of self-soothing mechanisms as people, with good parental attachments. The severity of exposure to trauma. We do know that more traumatic events, so people who go on ECMO as opposed to, come through the ICU with no problems, that's more traumatic, requiring, more prolonged intubation. Those kinds of things are more predictive of acute symptoms. And we do know that brain injury does increase the risk of post-traumatic stress disorder. So, some of the, I kind of mentioned a little bit about some of the biological models, and this is limbic hyperactivity. That means people whose emotional sense tends to be a little bit more activated and maybe have more episodes of PTSD. People, again, with more of a sympathetic nervous system that's activated. People who have disrupted endogenous opioid. So this means people who either were born with or may have had prolonged exposure to opioids before transplant. That actually means that their opioid receptors don't work as well. So our endogenous, our bodies, produce a lot of, pain-killing chemicals on their own. And so if you have prolonged exposure to opioids from outside your body, that can mess up your body's internal regulation of that. And so that, and self-soothing is an important part of, putting the past in the past when trauma happens. So prolonged exposure to opioids or other reasons for endogenous opioid dysregulation can increase risk of PTSD. And then dysregulated serotonergic modulation, which is, this is why the SSRIs like venlafaxine and the SNRIs like venlafaxine or the Lexapro and stuff are help with PTSD. And this is just a complex slide showing you that it's not one thing, and no one pill, of course, or one approach is necessarily going to work to help your brain heal from something like PTSD. So the treatments that we do use, if people are diagnosed with PTSD include, like I said, the SSRIs or other antidepressants like the SNRIs or tricyclics. One medication alone often does not, because it's such a complicated brain disease, doesn't necessarily treat. So sometimes people need to be on augmenting medications like lithium or Buspar or clonidine or something like Seroquel. There are some studies looking at marijuana. It's unclear to me that there's really good data that supports the use of marijuana. Anything that's actually that makes people dissociate can actually worsen PTSD. But dissociation along with active psychotherapy in the moment that you're dissociated may help you relearn and put the past in the past, so that their marijuana could have a role. So this is actually from the VA. They kind of like looked at big studies of people with PTSD and how they treated them. And, this is where the data lies, a significant benefit from the SSRIs and SNRIs, some benefit from some of the older antidepressants, and Remeron. Prazosin has definitely been shown to help with sleep and nightmares, and the tricyclics. We're not sure about the atypical antipsychotics as adjunctive, or other things like Wellbutrin and Buspar, and the old antipsychotics, gabapentin, lamotrigine, non-benzo hypnotics, prazosin for anything for PTSD in general, not just nightmares, or trazodone. We know there's no benefit from benzodiazepines, and in fact, we know that they're harmful. And so this, hopefully, if you remember nothing else that I say, you remember this, that if someone gives you lorazepam or oxazepam or alprazolam, Xanax, Ativan, Klonopin for your PTSD, it may help you feel less anxious, but we know that these medications actually increase your risk of prolonged PTSD and worsened. And then guanfacine, risperidol, and so some of the mood stabilizers and antipsychotics haven't been shown to help in PTSD. What is very helpful is therapy, and cognitive behavioral therapy is the one that's been studied the most. And this is really, helps you have a new appraisal of trauma, not excessively negative, and change what a person is perceived as sort of dogmatic negative consequences. It helps unlearn the strong associative memory. And exposure therapy, walking, writing, talking, virtual reality, those also can help kind of change the brain circuits that are sending the wrong messages that everything that you encounter in your life now, it continues to be a threat. Psychodynamic psychotherapy can help with the mistrust, the guilt, the anger problems with interpersonal relationships and self-esteem. And support groups can be very, very helpful. And this is one of the things that sometimes people with PTSD say, I don't want to go and talk with people to remind me about the trauma. But what we know is that actually working through bad experiences with people who share similar experiences can help build a sense of community, and also can help rework trauma into resilience and allow moving forward with new strength. And so these are actually very, very helpful. You have to sometimes convince people that it won't be scarier than it is helpful. No, so this is kind of why we're all here, as PTSD and medical care. So we know that they're really mutually interactive. We know that people have traumatic experiences while receiving medical care, especially in the ICU, especially if you have delirium in the ICU where you might get confused or hallucinate. That really increases the risk of developing PTSD. Waking up during surgery happens up to 2% of patients undergoing surgical procedures. And PTSD itself can lead to, us not taking good care of ourselves, either not taking medicine or not seeking care, because coming to the hospital can be a place that, reworks the trauma, or, that reminds us of the trauma, but it also can lead to, a lack of care and some emotional numbing, and therefore a lack of interest in self-care. PTSD itself can increase the risk of medical problems. So untreated PTSD increases the risk of cardiac disease. It increases or it really decreases our pain threshold, increases how we respond to pain. And we know that the treatment of medical problems actually can help people with PTSD, especially sleep apnea. So people with obstructive sleep apnea who use their CPAP can really decrease their PTSD symptoms. So I'm going to end sort of talking a little bit about resilience. So what is it that makes us resilient? Often it comes from having strong support, around the time of the trauma, after the trauma, but also in our lives. Ascribing meaning to the events, knowing that there's a reason, trying to think about that there's a reason that things happened, appreciating, the way that things went, knowing that bad things can happen and you might feel bad about it, but that doesn't mean that everything forward is going to be bad again. Having a motivation for a new approach to life. What are you going to do after transplant? What are you able to do that you weren't able to do before? Engaging in great self-care, exercise, diet, investing in your community. Those things help spark resilience. And then gratitude. We know that the daily gratitude can actually really decrease our blood pressure, increase our positive, outlook on life, decrease depression, and can really help build resilience. So whether that's, feeling grateful for the organ, writing a letter to the donor family, whether that's, being grateful to your family for supporting your doctors, or just being grateful for yourself for all the things that you're doing to help take care of your transplant or help take care of your family members. Just a moment every day of gratitude for, the sun coming up, that actually has an incredibly powerful impact. So as usual, I talk too fast, but that leaves us lots of time for questions or comments. And I thank you for your attention. And I'm gonna start with the Q&A here. So here's one that says, how do you define trauma? What does it include? So, trauma is essentially, as I said toward the beginning, it's any event that happens to you or you witness or you hear about for a close loved one that is potentially life-threatening, life or limb-threatening, where someone is essentially powerless to help themselves. Is this scale of pride? Yeah. So for kids, the diagnostic criteria are essentially the same. It's just that they don't tend to have nightmares and flashbacks that are, little movies of exactly what happened. They tend to have more symbolic kinds of nightmares, and they tend to have more behavioral issues rather than, because they don't have the same vocabulary for talking about their feelings. You might see more behavioral outbursts. When addressing, is past PTSD a detriment? No, it certainly would not preclude anyone from transplant. It's just the kind of thing that we like to know about going in. So if someone has active PTSD, the strong flashbacks, nightmares, and they're not able to come for care because, they're so scared to come to the hospital or to go out in public, then that's someone who needs to be in treatment now so that they can do well post-transplant. And then a history of treated PTSD, we just like to be aware of so that we can be on top of it right after if there's any recurrence, because we know that untreated PTSD can worsen someone's outcome. But it's not an absolute contraindication. But just like anyone who's really struggling emotionally, when they go to transplant, we need to help them get to be the best that they can be before transplant, so they do the best. Oh yes, people do absolutely get PTSD from ICD shocks. And basically the best treatment is, if it's that they're anxious all the time, and I've seen it happen in the hospital, people like who, are really hypervigilant to whatever's happening, and they know even like when their heart rate, and if they hear, they'll be like watching the monitor. So some of the things that we do are, first of all, some visualizations over like getting your heart rate down while you're watching the monitor, kind of retraining your brain that you have a little bit of control. And sometimes it can be, doing formal cognitive behavioral therapy or taking an SSRI. But we can actually do some mindfulness-based stress reduction in the hospital with the monitors around that, and sometimes that can help. Well, meaning, of course, is whatever means to you. So, depending, if you're coming from a place of religiosity or philosophy, or just thinking about how, here's an example. Let's just say, someone, develops end-stage renal disease, and they're going to need a transplant, and they come to transplant evaluation, and they're encouraged by their transplant doctors to reach out to family members to ask someone to be a live donor. So one thing you could think about is, oh gosh, I need to get a transplant and go through all this stuff, and I'm going to end up on dialysis, and I have to ask someone for this huge gift. Or you could reframe it and think about, this disease, as unfortunate as it is, has allowed me an opportunity to connect with family members that I haven't really talked with in a long time and haven't been close to, and allow them to the opportunity to help me get better in a way that they might not ever be able to do. And it's made me be more transparent with my family members. Or someone who's kind of a loner, now has to get social support in order to do well with transplant, has to reach out for help. It's an opportunity to think about how you may have like done your life differently. Or it could be, something, like now I'm learning to take care of my health in a new way. Or, I'm learning more about the whole, about organ donation, and now can, go out and be an advocate for for, live donation or for, donor cards. I mean, those kinds of things. Has COVID affected PTSD?
Hi, Dr. Chism.
Yes.
Hi, sorry,
Hi.
it's Talia. I also wanted to comment about that because that was going to be one of my questions.
Oh, sure.
Sort of, as well as far as meaning goes. I mean, and this is more of a comment, not a question.
Yeah,
One thing that we try to encourage, especially at Gift of Life, is to, like you had mentioned towards the end, how can this transplant that you're either waiting for, you received, help others? And that kind of can help attach a meaning to like your life moving forward. So either you're sharing your stories with other transplant recipients, and then that gives them hope and inspiration and, makes them feel more connected. Or like you had mentioned, really sharing it to increase donation registration so that there are more potential donors that can help save more lives. So I think a lot of sharing one's transplant story with other patients can be a real meaningful way to sort of live one's life post-transplant. And then the other thing, I've heard this from recipients before, and I really appreciate it, because you can't have a transplant typically other than living kidney or liver without a deceased donor. So one patient once said, now I live my life like my donor is watching. So it's almost like living for the person in a way that them and their family had said yes to donation to help save your life.
Yeah, I think those are all great examples, and I'm sure each of you can come up with them as well. I think the important thing is, the idea of reframing a negative event into a positive. Like what can you give? What have you learned? What have the people around you learned? What can they learn? What can they give? How do you function, in this community? I always say that transplant is like, when you go for transplant, it's like you're joining a family. It's another marriage, right? And so you have to, interact with a lot of different people that you might not have ever met before. And that experience itself can be, profoundly meaningful, because now you now are operating in a complex system where you can be an advocate for other people who might have to enter a complex system, and then you interact with people that you wouldn't normally want to interact with, but you have to. It can teach you skills about, getting along, and sometimes it's skills about patience, right? So we can look at, it's like, you can look at when someone like cuts you off on the highway, you can say like, oh, that jerk, why did they do that? Or you can say like, wow, I hope the thing that they're rushing to, isn't too bad, because they must be in an awful hurry, right? I know that I have to sit here. It's like really frustrating that when I come for my post-transplant visits that I'm waiting to see the surgeon, but maybe the reason that the surgeon's not available is because they're giving someone else a transplant, and what a great thing that is, right? So those are the kinds of things that can help turn, and I'm not saying, like every bad thing is great, or I'm not trying to be a Pollyanna, but, we know that bad things are going to happen in our lives. And so it's how we deal with them and then go on to live our lives that, that really helps us grow as people and be successful as people. Has COVID affected PTSD in transplant recipients? I mean, that's a really great question. I'm like, I don't know if you mean like the actual COVID itself or the experience of the pandemic and people being cut off. I mean, I think it's meant that, being connected and, is less. People were more isolated and more fearful, but I don't have any statistics that show that there's more PTSD post-COVID. This is a fascinating question. Is it possible to become attached to the cause of the trauma, e.g. looking forward to hospital appointments? I mean, I think that's, it certainly can be. And I think this is something we see, unfortunately, in pediatric patients, that like the only place that they, even though it may have been traumatic to be in the hospital, they also were very much cared for there, and being sick was an opportunity to be cared for, and certainly to something that about. And so that can happen. And sometimes people, who have a history of trauma do gravitate towards more risky situations, because either it's familiar or it reinforces a sense, of really a familiarity and the illusion that they might be able to learn to control it. It is kind of a complicated dynamic. To what extent is therapy the approach as opposed to meds? you know, therapy is probably just as good or better if you can access good quality therapy in a meaningful way. Sometimes medication allows you to have a decrease in symptoms, which makes therapy more possible. Using something like prazosin for nightmares is really important because, you know, people are not sleeping, they're not feeling well. You know, people who have recurrent panic attacks and a lot of depression or anxiety, starting an antidepressant, you know, for a while may be a good idea before therapy, you know, really kicks in. But you know, it's probably about the same. You know, that most studies show that CBT versus SSRIs, you know, work about equally well for depression, anxiety, and maybe a little bit better the therapy for actual PTSD. Most people don't get totally better on meds alone with PTSD. So, and in terms of like, you know, for transplant patients, you know, we don't want to add more meds if we don't have to. And so if we can get people into therapy instead of using medication, it really, really is probably better. A lot of people have psycho-emotional issues post-transplant, aren't properly prepared. Yeah. Is it because they're too, yeah. How can, you know, that is such a great question. I hope everyone can read this. I feel that a lot of folks have psycho-emotional issues post-transplant, aren't properly prepared for all the issues post-heart transplant patients face, like tachycardia, tremors, weakness, problems with rejection, neuropathy. Is it because they don't hear or too sick to really understand? How can programs better prepare patients for the bad things that happen post-transplant? I think that's such a great question. You know, I feel like I'm always like the one to bring all that stuff up when I see people. And it's like, you know, the worst case scenario person. And a lot of times people don't want to hear it because, you know, none of us really want to, you know, just like we don't read the, you know, the fine print of a lot of things, right? So what we have is a potentially life-saving treatment. And, you know, I don't want to know about like, you know, what isn't going to go well with it. And so that's a real struggle. I think, you know, one of the things that we can do is just kind of keep repeating that you need to be prepared for this, need to be prepared for that. And if you, you know, if you have risk factors for making some of these things more likely, you know, our transplant doctors and psych, we need to kind of keep reminding them. And so be prepared, know that we have a plan for it. I think talking to, you know, encouraging people to talk to other people who have been through it. I do think that that patient peers are often listened to, you know, more than doctors about some of these things. So I do think that's, you know, the work that Gift of Life is doing and some of the transplant centers are doing around getting folks to come to the patient groups before transplant, I think is really helpful. How do I approach preparing patients on the pre-side of transplant for the possibility of acute trauma issues? I mean, again, I just sort of talk about it, especially someone who's had a history. You know, and I mentioned that can happen, and I'll try to talk a little bit about what some of the symptoms are and what you know, what to watch for, and that again that we are going to be aware of it, and that we're going to, you know, treat people, but we do, you know, let them to know to take it seriously. Basically, can a diagnosis, e.g., a very
Dr. Chism,
yeah.
So sorry.
That's okay.
So I didn't realize not everyone can actually see the question. So someone asked if you could read them a little slower so they know.
Oh, sure. I apologize. Sure. So the next question is, can a diagnosis, I assume you mean receiving a diagnosis, e.g. very serious cancer, trigger PTSD? That's a good question. I mean, I think if someone gets PTSD, then they got it from what they got, if they perceive it as a trauma, you know, because there are specific diagnostic criteria for what PTSD is, you know, if they have it, then they have it. You know, so not what is traumatic to one person isn't necessarily traumatic to everyone else. Is it possible to actually get rid of PTSD, since we all know there's a high chance of the trauma that created in the first place will happen? So I don't see how the fear can subside. Well, I think that's an excellent question. The fear might not go away, you know, because fear is a natural and important human emotion, but the way that we experience trauma and the things that go wrong in our brain to create post-traumatic stress disorder, if you're talking about an individual person, we can treat. Can we get rid of it as a society? Maybe not. But I think, one part of therapy is actually about kind of exposure to bad things, with the knowing that in a context where exposure to bad memories or exposure to scary situations in a context where nothing bad is going to happen. And so you train your brain that just the threat itself isn't necessarily meaning something bad will come to fruition. I guess this is more of a statement. Moving from pediatric care to adult care is also such a traumatic event for the patient. Care in adult world is so different because pediatric is looked after so different. The care on the psychosocial is also cared for and looked at differently. I can't get a definite answer on correct medication. It gets overlooked. I wish they'd make it more a priority. Yeah, I think, Tessa, you're totally right that the transition from pediatric to adult transplant is really complicated. And, we've tried a lot of different approaches to, having a day, before the pandemic, and this kind of got derailed, but we really wanted to have an idea about, having a day where patients who are transitioning from pediatric to adult transplant would kind of come and meet everybody all at once and kind of get to know us and, make that a more comprehensive approach. And I think, unfortunately, we got a little bit derailed with the pandemic, but also, not everybody wants to come at the same time or is available to. And so we're kind of trying to figure that out, because I think that's a huge issue. I know people who work in sickle cell, for instance, often the adult sickle cell doctors will go to the pediatric clinics to meet the patients before they transition. I think it's really, really, really important, because you're right, we just don't have the same resources in adult transplant as we do in pediatric, and there's just not enough support, and it really, we need to do better. There's no question. Does trouble regulating body temperature? I mean, anything that as a part, so one symptom does not make PTSD, but there are many symptoms of PTSD. Like I put up that whole thing. And a lot of them have to do with dysregulations in our autonomic nervous system, which helps control our body temperature and our heart rate and our respiratory rate. And so all kinds of things can go wrong with that. And then when we know, when we start to associate feelings in our body with bad emotions, feelings in our body then can start to trigger bad emotions. And that, I mean, that really is the essence of what PTSD is that your brain is telling you that the traumatic event that you experienced is still going on. And so all the things that are around it will be triggered in your body and your mind. Is TMS a possible treatment? I mean, people are looking at TMS for, this is transcranial magnetic stimulation, which is sort of like ECT light using a magnet. And they're looking at it for a lot of different things, but I'm not aware of it being shown to be a robust treatment for PTSD yet.
Dr. Chism, while we wait to see if more questions come through, I'm wondering if you could talk a little bit about survivor's guilt, since that's a pretty common experience for patients and families.
Yeah. Well, and there's a couple different ways that this plays out, right? So first of all, there's the guilt of receiving an organ from a deceased donor that sometimes people really struggle with. This is something I really try to look for in the pre-transplant period, as someone who might be at risk, based on a history of depression or anxiety or low self-esteem or a history of trauma, because we really need to address that up front. When it happens kind of unexpectedly afterwards, we just have to, we talk it through. And one of the first things that we have to unpackage is this idea that someone died for me. So because that's not true, right? If you have a deceased donor organ, someone did die and you have that organ, but they didn't necessarily do it for you. That's not your responsibility. You didn't make that happen. And so that's one thing we have to kind of work on. And then thinking about, again, reworking the meaning of it. If you have received a gift that somehow you don't feel worthy of at this time, what can we do in order to help you live your life in such a way that you can that you can feel worthy. Now, the part about families, maybe if someone passes from a transplant, or that, if someone dies before transplant, or if there's a lot of complications and folks can't kind of come home the way that they were, and family members may feel that they didn't do enough, or that they're somehow responsible, and that can kind of take a life of its own, because we engage families so much and put so much responsibility on them. It can be negatively interpreted as that if something goes wrong, that it's somehow their fault. But again, I think like any other bad event, you have to start to help yourself think about how you're not in control of everything. Things are not your fault. You are, permitted to, live a happy and healthy life, irrespective of what might have happened to other, people, and, in your life. And you have to process. And usually guilt comes from, self-esteem issues, or also, an exaggerated perception of your own ability to control events. And those are the things that people have to work on. I hope I answered your question in a way that was useful. If there's some aspect of it that I didn't bring up, I'd appreciate you telling me, Talia, because I know this is something that you deal with a lot.
Yeah, no, I think that was really helpful, especially when you think about it in the multiple ways that one can experience it. Dealing almost like grieving for your donor, as well as feeling like you don't deserve it, or other people should have gotten it before you. We hear this a lot with adult patients, and like, maybe this organ should have went to a child, which the system that's in place right now in the United States is intended to be as equitable as it can be. So again, you're not taking an organ from someone else necessarily, and you're not the cause of someone's death. But I think it also connects back to like the meaning making piece. If you feel like you're not worthy, what can you do to feel more deserving, and how can you better support your community and the community at large, so that you're making meaning out of this new gift? There's two other questions in the, actually one is about dialysis, which I'll let you answer. And then the other one before that one, so I did mention we are recording this, and I'll send it to participants. And Dr. Chism, if there's any of the slides that you feel comfortable sharing that people might be able to have as well, you can let me know. We can send whatever resources out.
Okay. So the question is, could you speak to PTSD in the dialysis experience? Is this where the framing becomes so important? Working with kidney patients, dialysis is such a complicated experience. It keeps the patient alive, but it's also a terrible, possible traumatic experience that you repeat 3 days a week. I think those are great questions and comments. I think you're absolutely right. It's about the framing. But I would say a couple different things. So, there's PTSD, from, maybe the hospitalization where someone, developed kidney injury. That's one thing. The dialysis experience itself, if it's an ongoing experienced as an ongoing trauma, this is somebody who really needs to get into treatment right away, because, to have to show up for something that you experience as traumatic every single time is going to be tremendously, demoralizing, lead to a lot of, to defeatist behavior, people not showing up. I think you have to think about it as, this is something that I need now. I might hate it, but it's something that I have to do all the other things that I want to do. If we can unpackage aspects of it that are particularly problematic, we want to do that too. Is there anxiety around it? Is there pain? Is there discomfort? Is your shift one that means you have to get up at 3 a.m. to get to? And then that begs the question of like, should you be, advocating for yourself with you and your family member over possibly doing PD, like, or maybe, home dialysis in some way? Like, what are some other options also to take more control? Because I do, agree, as we need the dialysis centers, not everyone is capable or wants to deal with that, or may have too many medical problems to do it at home. but it certainly can be a very disempowering experience. And yeah, it takes a lot of work. I hope I answered that. Let's see. It's taken me a long time, 5 years post daughter's transplant, to appreciate how PTSD can impact so much and so negatively. Is there any reading you recommend for parents, caregivers of peds teens to prepare and to send home? I can't think of anything offhand. I mean, there's a really interesting, book about PTSD that came out a couple of years ago called Written on the Body that is, very interesting and kind of talks about, different conceptions of PTSD and how to confront symptoms, with movement. But let me get back to you. I don't have anything like unfortunately, I'm not a child psychiatrist, so like all that stuff is not at the tip of my fingers. I wish someone would write like a great memoir about the transplant experience so that we could really see that. Because one of the greatest books that I've ever read about like bipolar affective disorder is Kay Redfield Jamison's An Unquiet Mind. And I always encourage people to read that because that lived experience explains it so well. So if anybody knows of a great memoir of PTSD, otherwise I would say Written on the Body is a very good kind of journalistic exposure. And, I think we try so hard to prepare people for transplant, and there's so much about expectation, and you need to do this, and you need to take these medicines, and you're going to have to come for these labs, and you have to keep your insurance. And I agree that sometimes the emotional part gets lost. But again, I encourage all of you to take your stories out there, meet with other people, because I think once people see that, yes, it can be really hard and there can be a lot of negative things that happen, but when you're prepared and on top of this and aware that symptoms might come and therefore getting treatment as soon as possible, or thinking through, like the thing that I always talk to patients about before transplant when I see them is developing coping skills that are yours. And this is where therapy or mindfulness-based therapy is so effective, because you don't have to wait for someone to bring you a pill, no matter where you are, when you're, lying, in the PACU, waiting to go in, you can do your breathing or your mindfulness, or, or if it's music that you need, all of those skills, that's what you want to start honing, all the skills that you possibly can going in, so that you can be the strongest that you can be mentally going into transplant, to be prepared. So, all the good habits, if you can manage them. And like, if your loved one is very debilitated before transplant, even just doing, little things, maybe they can't get out and go for a walk, but, sitting by a window and, doing, wrist circles and ankle circles, if that's possible. And all of these things, like every little bit helps. And then, again, being an advocate, when you come to clinic with your loved one, if they're not doing well, that they're not sleeping or they're having bad dreams, like bring it up. I come to post-transplant clinic, or my NP goes, we're there as a resource for you. And hopefully your transplant programs have, similar.
Thanks, Dr. Chism. So we don't have any additional questions so far. I just want to recap a little bit of what you talked about today, which is PTSD is absolutely possible as a transplant patient or a caregiver based on all of the very potentially traumatic experiences one can have when they go through the transplant process. So it's absolutely possible. If you feel like that's something that you've dealt with, it could very well have happened to you. And then finally, dealing with those things, individual therapy groups, support groups, with other transplant patients, as well as medication. So not to be afraid of pursuing any of those options to kind of work through what you're experiencing. In the follow-up email I send all of the participants, I'll include, because I know everyone's from all over the country, Psychology Today is a really great website to identify a therapist, and you can filter it by chronic illness. So you could find a therapist who has experience with patients, and individuals with chronic illness. So that would be a good resource to consider. And you can also filter it by your insurance, by pet, all those things. Unfortunately, many things are still available virtually, so you could potentially find a therapist who's not even super close to you. And again, most hospitals have support groups for their transplant patients. We have our virtual support groups. Please participate, even if you feel like you're doing super well. It's a great opportunity to share your story and to support others who might not be, who might be newer or still struggling a little bit. And then finally, we'll include the recording in the follow-up email as well as the survey. It's really important that you complete the survey because it really helps us as we move forward. And I think that's it. Dr. Chism, do you have any final thoughts you wanted to add?
No, I really appreciate the opportunity. And yes, I cannot underscore enough how if you could please, if you're someone who's doing well, come to group anyway. And because again, when someone's struggling, just knowing that someone can get through it can be an incredible motivator and an idea of hope, So I think this is really important. And I'm so glad that everyone came today. And the only other thing is that looking for a good cognitive behavioral therapist, you can try the Academy of Cognitive Therapy website, and they also have like a geographic referral, and that's a good way to get to get a good doc. And so sometimes a therapist, the first fit is not the right one, but don't give up. That doesn't mean that hope and treatment is not out there.
Yes, that actually reminded me. There's also a lot of not therapy-wise, but good apps out there for mindfulness.
Yes, yes.
And I know mindfulness and meditation can be a little bit scary to people, but these apps like completely guide you. You don't have to, figure it out on your own, especially if you have sleeping issues, like they could be really beneficial. So I could try to include some of those apps in the follow-up email as well.
You're absolutely right. Those are incredible. And it's just a couple minutes a day, whatever you want. And some of them just have relaxation exercises for going to sleep at night. And it's absolutely, it changes your brain. It's in a good way. And they're very easy to use. And some of them were free, in the pandemic, like Calm and stuff like that. So.
Yeah, that also reminded me as we're closing out that there's some gratitude apps also. Because gratitude is so important to practice, and sometimes that can feel a little overwhelming. So there's apps just to help journal, what you're grateful for, which also reminds me that expressing your gratitude is also, you could also do it by writing to your donor family. I know that can be a little scary. Many people don't know what to say. We do have a webinar on our website about writing to your donor family, and I think also about survivor's guilt. So I would encourage you to watch those, because writing to your donor family is a really wonderful way to express your gratitude and sort of reconnect to the purpose of your transplant. We are not offering CEUs for this program since it is a patient focused webinar, but we could provide a certificate saying you participated, just we are not providing CEUs. So I think that's it for today. There's a few more comments in the chat if you all are reading them. Again, look for the email with all of our follow-up resources, the evaluation, the recording. Thank you, Dr. Chism, so much for your presentation today. It was clearly very important, as so many people were engaged, and we had so many participants from all over the world. I don't know if you saw, we had some people in New Zealand. Yeah, we had 2 patients at least I know in New Zealand.
Oh, wow. That's so cool. I'm very gratified.
Yeah, one who's waiting and one I think who was transplanted. So thanks everyone again for participating, and hopefully we'll see you next month at our next program. Have a great week.
So much. Thank you.